Imagine this, it's 3 a.m. on a busy medical ward. A nurse hands you a set of blood results. It's the urea and electrolytes, which are back from earlier today. The creatinine has doubled since yesterday and the potassium is borderline high. You do need to act now. So what do? Hello and welcome to our YouTube channel. My name is Camille and I'll guide you through one of the most commonly requested blood panels in hospital and primary care, which is the U&E or urea and electrolytes. By the end of the video, you'll understand the basic purpose of the tests, the basic kidney physiology, and what each parameter means. You'll also understand how to interpret them in real clinical scenarios. We'll do this by assessing two clinical cases, one of an acute kidney injury and the second showing a hyperkalemia. So, why do we do urea and electrolyte blood monitoring? U&Es are one of the most commonly ordered blood tests in the NHS, and that's for good reason. They give us a quick snapshot of the kidney function, hydration status, and electrolyte balance. We order U&Es in a wide range of settings for acutely unwell patients in A&E, pre-operatively as part of routine assessment, for monitoring patients on medications like ACE inhibitors or diuretics, and for anyone with suspected kidney disease. Dehydration and electrolyte imbalance also play a part. Think of the U&Es as a vital part of the patient's safety net. The blood test can help you detect kidney injury, highlight certain electrolyte derangements that can cause arrhythmias, and guide treatment decisions such as IV fluid choice. They can also help you choose your drug dosing and also escalation of care. To interpret U&Es properly, you need to understand some basic kidney physiology. Each kidney contains about 1 million nephrons, which are the functional unit responsible for filtering the blood. The blood enters the glomerulus, where filtration removes waste products and excess water. The tubules then reabsorb or excrete sodium, potassium, and other electrolytes to keep the body's balance just right. When kidney function is impaired, whether from obstruction, hypoperfusion, sepsis, or nephrotoxic drugs such as waste products like urea and creatinine, these can accumulate in the blood. Electrolyte balance can also be affected, leading to potentially life-threatening complications with hyperkalemia. When interpreting U&Es, what we're really asking is how well are the kidneys performing their job at filtering and maintaining homeostasis. So let's go through each parameter one by one. Urea. Urea is the waste product of protein metabolism. It is filtered by the kidneys and excreted in urine. High urea can indicate dehydration, renal impairment, or increased protein catabolism. For example, in upper GI bleeding. Low urea can be seen in liver failure, malnutrition, or overhydration. Creatinine. Creatinine is a breakdown product of muscle metabolism. It is produced at a relatively constant state and is freely filtered by the glomerulus. This makes it a good marker for kidney function. A rising creatinine usually indicates a declining glomerular filtration rate. Remember, creatinine is influenced by muscle mass, so an elderly patient may have a normal creatinine despite a significant kidney injury or impairment. The eGFR, estimated glomerular filtration rate, is calculated using the creatinine, age, sex, and ethnicity. It gives a more accurate picture of kidney function than creatinine alone. eGFR is crucial for staging chronic kidney disease and adjusting drug dosing. For example, many antibiotics and anticoagulants require dose adjustments based on the eGFR. Sodium. Sodium is tightly regulated and essential for fluid balance and nerve function. Low sodium or hyponatremia can be caused by overhydration, SIADH, or heart failure. High sodium or hyponatremia usually indicates dehydration or diabetes insipidus. Both require careful interpretation in the clinical context. Potassium. Potassium is vital for heart conduction and muscle function. Hyperkalemia is one of the most dangerous electrolyte abnormalities because it can cause life-threatening arrhythmia within the heart. Causes can include acute kidney injury, potassium-sparing diuretics such as spironolactone, ACE inhibitors, and tissue breaking down in conditions such as rhabdomyolysis. Hypokalemia can occur with vomiting, diarrhea, or diuretic use and can lead to muscle weakness and arrhythmias as well. So let's look at a case. Mr. Thompson is a 75-year-old man admitted with urinary retention due to benign prostatic hyperplasia. His urea and electrolyte blood tests show creatinine has doubled from the baseline, urea is high, and eGFR has dropped. This is an acute kidney injury likely due to post-renal obstruction. The results are shown as here. In this case, your immediate priorities include relieving the obstruction. You could do this, for example, by inserting a urinary catheter and monitoring the urea and electrolytes closely for recovery. You'd also be wise to review the medications, withholding nephrotoxic drugs such as non-steroidal anti-inflammatories or ACE inhibitors until kidney function improves. This is another case. Mrs. Patel is a 68-year-old female patient presenting with heart failure, taking spironolactone and an ACE inhibitor. She comes in for her routine bloods and her potassium is 6.2. Creatinine is slightly up from baseline and EGFR has dropped modestly. Here are her results. The immediate management would be to stop the offending agent, most likely to be spironolactone, repeat the potassium urgently, and start treating hyperkalemia according to your local protocols. This may include giving IV calcium gluconate, insulin and dextrose, and potassium binders if required. Remember, U&Es are much more than just numbers on the screen. They tell us a story about the kidney function, fluid balance, medication safety, and you should always interpret them in the context of the clinical picture. You should look at trends rather than isolated values and consider the patient's baseline and comorbidities. When you see a rise in creatinine, ask yourself, is it from a pre-renal cause, a renal cause, or a post-renal cause? When potassium is high, think about drugs, renal function, and urgent cardiac risk. And most importantly, act early. AKI and electrolyte imbalances can be treated rapidly if recognized and treated, but can be life-threatening if missed. So next time you get some U&Es, don't just glance at the numbers, take a moment to interpret them. Think about the physiology and consider the trend. So thank you for watching, and if you found the video useful, please consider sharing it with your colleagues and subscribing for more clinical education content.